Welcome everyone, and thank you for joining me today. I'm excited to introduce our topic, exploring types, measurement, and impact on gas exchange and breathing patterns. The title might sound quite detailed, but rest assured, we'll break it down and make it clear. Over the course of this presentation, we'll cover the fundamentals of pulmonary ventilation, different types of breathing, how we measure these processes, and their effects on gas exchange. So, let's get started and dive into this important area of respiratory physiology. Let's dive into the importance of understanding pulmonary ventilation and dead space. First, classifying ventilation is crucial because it helps us assess how effectively the lungs are functioning. By understanding different types of ventilation, we can identify abnormalities that might indicate respiratory issues. Now, dead space is a key concept here. It refers to those parts of the respiratory system where no gas exchange actually takes place. Recognizing dead space helps us understand the efficiency of ventilation. Next, let's clarify what ventilation truly means. Ventilation is simply the process of moving air in and out of the lungs. This movement is essential because it ensures that oxygen reaches the blood and carbon dioxide is removed. Without proper ventilation, gas exchange can't happen effectively. So, in summary, understanding the overview of ventilation, including these components like dead space, is fundamental in evaluating respiratory health and function. Let's take a closer look at the comprehensive understanding of pulmonary ventilation and dead space. When we talk about dead space, we're referring to areas in the respiratory system where air is present but no gas exchange occurs. There are three main types to consider. First, there's anatomical dead space, which includes the conducting airways like the trachea and bronchi. These are passages that deliver air to the lungs but don't participate in gas exchange themselves. Next, we have alveolar dead space. This is the air and alveoli that are ventilated but not perfused with blood, meaning no gas exchange happens there either. Finally, the third type is physiological dead space, which is essentially the sum of the anatomical and alveolar dead spaces. It represents the total amount of ventilation that doesn't contribute to effective gas exchange, what we call wasted ventilation. Understanding these distinctions helps us grasp how ventilation efficiency can vary and why certain conditions impact oxygen exchange. This concept ties into the overall theme of optimizing respiratory function and assessing lung health. Let's take a closer look at the comprehensive understanding of pulmonary ventilation and dead space. First, we'll focus on the anatomical dead space, often abbreviated as VD. This is a crucial concept because it helps us understand where no gas exchange occurs during breathing. Anatomical dead space includes all the conducting airways from the mouth and nose down to the terminal bronchioles. Essentially, these are the pathways that air travels through, but where no oxygen or carbon dioxide exchange takes place. Now, surgical removal of parts of the airway or the placement of artificial airways can change this volume. For example, if a segment of the airway is removed or bypassed, the anatomical dead space decreases. Conversely, placing an artificial airway, like a tracheostomy tube, can sometimes increase this space. There are also factors that can cause slight increases in dead space during normal breathing. Deep inspirations, bronchodilation, or certain hyperinflation diseases, such as COPD, can lead to marginal increases in the volume of anatomical dead space. However, in clinical practice, this volume remains fairly constant. Except in cases where surgical procedures are performed or artificial airways are introduced, we generally see little variation in dead space volume. It's important to note that no gas exchange occurs within this anatomical dead space. The air simply fills these conducting pathways without participating in oxygen or carbon dioxide transfer. In summary, anatomical dead space comprises the conducting airways from the mouth and nose all the way down to the terminal bronchioles. Understanding this helps us appreciate how ventilation works and how various interventions or conditions can influence respiratory efficiency. Let's dive into a comprehensive understanding of pulmonary ventilation and dead space. When we talk about measuring dead space, there are a couple of key techniques to keep in mind. One is the Fowler technique, which is a classic method, and the other involves pulmonary function tests, such as the single-breath nitrogen elimination test. These methods help us quantify how much air in the lungs doesn't participate in gas exchange. A more precise way to estimate dead space is by relating it to lung size, specifically to a person's ideal body weight. On average, it's about 1 milliliter per pound of IBW. So, if you know someone's ideal body weight, you can get a good estimate of their dead space volume. Now, when we look at typical anatomical dead space in adults, it's approximately 150 milliliters. This figure provides a useful reference point when assessing lung function and ventilation efficiency. Finally, measuring anatomical dead space is crucial because it helps us understand the portion of each breath that doesn't reach the alveoli. This measurement is fundamental in diagnosing and managing respiratory conditions, ensuring we have a clear picture of how ventilation is functioning in different individuals. Let's take a closer look at the concept of dead space in pulmonary ventilation. This slide emphasizes that when we talk about dead space, we're referring to areas in the lungs where air is present, but no gas exchange occurs. Now, if this dead space becomes abnormal or increased, it actually reduces the surface area available for gas exchange. This means less oxygen gets into the blood and less carbon dioxide is removed, leading to inefficient ventilation. This situation results in what we call wasted ventilation, because a portion of the air we breathe in isn't contributing to oxygenation. Moving on to the impact on gas exchange, decreased pulmonary blood flow is a major factor here. Conditions like low cardiac output or pulmonary embolism can cause blood flow to be reduced or blocked, and that further worsens the mismatch between ventilation and perfusion. Now, let's focus on alveolar dead space specifically. This is the volume of air that reaches the alveoli. That's where gas exchange should happen, but isn't actually perfused with blood. Think of it as air in alveoli that are ventilated but not perfused, so no oxygen gets into the blood, and carbon dioxide isn't removed effectively. We often denote alveolar dead space as VD, and understanding this helps us grasp how different pathological states can impair overall lung function. Recognizing these concepts is key to understanding how various conditions affect oxygen delivery and CO2 removal in patients. Let's take a closer look at what we mean by a comprehensive understanding of pulmonary ventilation and dead space. Essentially, this measure reflects how efficiently our lungs are exchanging gases. When we talk about the significance of physiological dead space, we're referring to the portion of each breath that doesn't participate in gas exchange. The key point here is that physiological dead space, often denoted as VD, is made up of two components: anatomical dead space and alveolar dead space. The formula for calculating physiological dead space is straightforward. It's the sum of these two parts. Anatomical dead space refers to the air in the conducting airways, like the trachea and bronchi, where no gas exchange occurs. Alveolar dead space, on the other hand, involves alveoli that are ventilated but not perfused or participating in gas exchange at that moment. So, when we say physiological dead space is the total dead space in the lungs, we're acknowledging that it includes all the areas where air is present but gas exchange is either limited or absent. Understanding this helps us appreciate how the lungs work as a whole and why measuring dead space is vital in assessing respiratory efficiency. Let's take a closer look at the comprehensive understanding of pulmonary ventilation and dead space. On this slide, we're focusing on the summary of dead space types. First, we have the total dead space, which is the sum of the anatomical and alveolar dead spaces. Think of this as the total amount of wasted ventilation volume, the air that fills certain parts of our respiratory system but doesn't participate in gas exchange. This total is essentially the sum of VD, anatomical, plus VD, alveolar. Now, in cases of physiological dead space, we're talking about an abnormal condition. This occurs when air gets into alveoli that aren't perfused with blood, which actually reduces the surface available for gas exchange. So, even though the air reaches the alveoli, it doesn't contribute to oxygen or carbon dioxide exchange. Focusing on alveolar dead space specifically, in adults, this is roughly 150 milliliters, or about 1 milliliter per pound of ideal body weight. This is the air in the alveoli that isn't used for gas exchange because these alveoli are not perfused. Lastly, the anatomical dead space refers to the air in the conducting airways, like the trachea and bronchi. This air doesn't reach the alveoli, and therefore, no gas exchange occurs there. By understanding these different types of dead space, we get a clearer picture of how ventilation efficiency can be affected in various conditions, which ties into the overall theme of respiratory function and health. Let's take a closer look at the comprehensive understanding of pulmonary ventilation and dead space. First, VT stands for tidal volume, which is the amount of air inhaled or exhaled during normal breathing. VD represents dead space volume, the portion of each breath that does not participate in gas exchange because it stays in the airways. The respiratory rate, F, indicates how many breaths we take per minute. Now, when we talk about the components of the formula, VA, or alveolar ventilation, is usually expressed in liters or liters per minute. This is the effective volume of air that actually reaches the alveoli, where gas exchange occurs. The key formula here is VA equals VT minus VD times F. This means that to find the alveolar ventilation, we subtract the dead space volume from the tidal volume and then multiply by the respiratory rate. In essence, we're calculating the volume of air per minute that is truly available for gas exchange. It's important to understand that alveolar ventilation is a part of the overall minute ventilation, which is the total volume of air inhaled or exhaled per minute. But alveolar ventilation specifically refers to the effective portion that reaches the alveoli, making it critical for efficient gas exchange. Finally, this concept helps us understand how ventilation efficiency impacts oxygen delivery and carbon dioxide removal. By controlling tidal volume, dead space, and respiratory rate, we can optimize alveolar ventilation and improve respiratory function overall. Let's take a moment to understand how alveolar ventilation affects carbon dioxide levels in the lungs. When alveolar ventilation increases, or VA goes up, we see a decrease in the partial pressure of alveolar CO2, known as PaCO2. This is what we call hyperventilation. Conversely, if alveolar ventilation decreases, PaCO2 increases, leading to hypoventilation. Now, it's also important to recognize the role of dead space air. Remember, dead space air doesn't participate in gas exchange because it remains in the conducting airways. All the CO2 that we exhale actually comes from alveolar ventilation, the part of ventilation that reaches the alveoli where gas exchange occurs. This relationship between alveolar ventilation and PaCO2 is crucial because it highlights how tightly linked our breathing rate and depth are to the regulation of CO2 in our body. If VA goes up, PaCO2 drops, and if VA decreases, PaCO2 rises. So, understanding these dynamics helps us grasp how the lungs maintain homeostasis and respond to different physiological demands. This is a fundamental part of comprehending pulmonary ventilation and the impact of dead space on our overall respiratory function. Let's take a closer look at the parameters in the Boer equation. PaCO2, as you know, is the arterial carbon dioxide pressure, while PeCO2 refers to the exhaled CO2 pressure. These values are essential for understanding how effectively gas exchange is occurring in the lungs. Clinically, we often calculate the dead space to tidal volume ratio, or VD over VT, using the Boer equation. This formula is quite straightforward. VD/VT equals the difference between PaCO2 and PeCO2 divided by PaCO2. It helps us quantify how much of each breath is effectively dead space, that is, not participating in gas exchange. Now, breathing patterns play a significant role here. Shallow breathing tends to increase VD/VT because a larger proportion of each breath remains in the dead space, whereas deeper breaths tend to decrease this ratio, as more air reaches the alveoli. Remember, though, that anatomical dead space remains constant regardless of how deeply you breathe. Under normal circumstances, this ratio usually falls between 30% and 40%. That's the typical range we expect in healthy individuals. So, what does the VD-VT ratio really tell us? Essentially, it represents the fraction of each breath that doesn't participate in gas exchange, dead space relative to tidal volume. This ratio is a valuable indicator of ventilation efficiency and can signal issues like ventilation perfusion mismatch. In summary, understanding the dead space to tidal volume ratio helps us comprehend the broader picture of pulmonary ventilation and the efficiency of gas exchange, which is at the heart of our overall focus on respiratory health. Let's take a closer look at how pulmonary ventilation and dead space are interconnected. Breathing patterns play a crucial role in determining not just how much air reaches the alveoli, but also how effectively CO2 is expelled from the body. When we talk about alveolar ventilation, we're referring to the amount of air that actually participates in gas exchange. Different breathing patterns can significantly influence this, even if the total minute ventilation remains the same. For example, tachypnea, which is rapid breathing, might seem like a good way to increase ventilation, but if the breaths are shallow, what we call hypopnea, it may not effectively clear CO2. Conversely, slow breathing or bradypnea might reduce CO2 removal, affecting blood gas levels. Deep breathing or hyperpnea can enhance alveolar ventilation, improving gas exchange efficiency. It's important to understand that the same minute ventilation, or VE, can produce different alveolar ventilation rates and CO2 levels depending on the breathing pattern. This highlights how vital the pattern itself is, not just the total amount of air moved. The rate and depth of breathing directly influence alveolar ventilation and the VD-VT ratio, dead space over tidal volume. Changes in these factors can alter how well we ventilate the lungs and remove CO2. In summary, the way we breathe, whether fast, shallow, slow, or deep, has a significant impact on ventilation efficiency and CO2 levels. Recognizing these patterns helps us understand respiratory function better and can guide us in managing respiratory conditions effectively. Let's take a moment to review some key points about pulmonary ventilation and breathing patterns. When breathing slows down or becomes shallower, we call this hypoventilation. This decrease in rate or depth causes carbon dioxide levels in the alveoli to rise, which can be problematic if it persists. On the other hand, hyperventilation occurs when breathing becomes faster or deeper than normal, leading to a decrease in alveolar carbon dioxide. This can cause issues like dizziness or tingling sensations. Now, the normal breathing pattern we refer to as eupnea. It's the effortless, spontaneous breathing that maintains a healthy balance of alveolar CO2 levels. Throughout this presentation, we've emphasized how crucial it is to understand these patterns, as they reflect the body's attempt to maintain homeostasis and ensure proper gas exchange. Recognizing abnormal patterns like hypoventilation and hyperventilation helps us appreciate the body's responses to various conditions and underscores the importance of normal respiratory function for overall health.